Myelofibrosis is a very challenging disease. There have been many treatments over the years, but none of these treatments have been really disease modifying. We haven't had any curative treatments other than an allogeneic stem cell transplant. And this is a treatment which is only available for a small subgroup of patients. And even in that setting, there is a treatment-related mortality of 25%. So I think we definitely need better treatments for myelofibrosis. Calreticulin is a very fascinating target. The mutation in the protein is the result of a frameshift mutation, which leads to a novel C-terminus. And because it's a frameshift mutation, all the described mutations, they have the same C-termini, which means that you can develop a binder, an antibody, that would be able to target all of these mutations. The majority of them mostly are deletion 52 and insertion 5, obviously. Now, the other fascinating aspect of this mutation is that in order to drive the disease, it has to bind to the thrombopoietin receptor in megakaryocytes and to be expressed on the surface of megakaryocytes and stem cells, aberrantly activating the thrombopoietin receptor and driving the disease. And this is exciting because that means that it is expressed on the surface of malignant cells, it is not expressed on normal cells, and it is a disease-driving mutation. So that would be the three main goals of any immunotherapy. It would be the three main attributes of any immunotherapeutic target. And CAR T cells is the most powerful immunotherapy that we have. And what we have done is we created the 4-1BB second generation CAR T, which has shown excellent efficacy on in vitro studies against murine and human cell lines, that they are bearing the mutated calreticulin target on the surface without affecting any irrelevant targets, like we test against the thrombopoietin receptor, wild-type calreticulin, and a plethora of other antigens, and there was no off-target toxicity. Then we moved into testing our CAR T against CD34 positive cells isolated from patients, and we have seen that our CAR T was able to eliminate 60 to 70% of them, which it may well be all of the malignant stem cells, because the burden of the mutation is never 100%. Given that it is a heterozygous disease, when we test for the VAF, for the val allele frequency, it's usually 30 to 40%, which means around 60 to 70 or 80% of the stem cells will be mutated. And this is important because that means if our CAR T eliminates all the malignant ones, there would still be a significant number of non-mutated normal stem cells that will be able to proliferate and to restore normal hematopoiesis. And lastly, we tested how well our CAR T functions in a murine model. So we used the Marimo cell line, which is a quite aggressive cell line. NSG mice will die within a few weeks with this cell line. And our CAR T was able to control the growth of this cell line and prolong survival of these mice significantly. We also tested for the expansion of the CAR T in these mice, and the T cells were able to expand. And also we looked for tumor in the marrow of these mice and their spleens, and again we found very little tumor. And we compared that with a negative control CAR T, which in this instance was a CD19 CAR T. So to summarize, I think our novel CAR T cell therapy for mutated calreticulin myelofibrosis is able to selectively eliminate calreticulin mutated stem cells, and there might be more powerful CAR Ts coming, something we're exploring. We want to even further improve this treatment. This is the second generation CAR T only. And ideally, we would like to take this into first-in-human phase 1 trial, where other important questions about maybe unexpected toxicity, cytopenias should be answered, but also that would be the real test for the efficacy of this exciting therapy.